Welcome to Health Management Academy. The subject today is patient experience with a special emphasis on the ED flash meeting. Now, let's see an example of an ED flash meeting. The flash meeting should occur in the ER so that the on-duty physician can be involved. Before arriving at the flash meeting, attendees should review the statistics and make notes of any key observations and prepare questions. It is especially important for the CEO to review reports and prepare questions for attendees.
Good morning, everybody.
Good morning.
Let's start today's flash meeting by reviewing yesterday's metrics. We saw a total of 56 patients. That is down slightly from what we've been seeing on a daily basis, but we did have a 41% admission rate.
Good job.
Yesterday, if you recall, we focused in our flash meeting on our over 65 consults, and we did a phenomenal job with a total consult over 65 of 86%.
We put emphasis on patients over 65 because of the high likelihood of comorbidities, such as hypertension, cardiac disease, diabetes, etc. The more consultations, the more communication with the patient's primary care physician, the better. By being more familiar with the patient, the provider might elect an admission, especially if the patient had a history of noncompliance or had little support systems available.
I will now review yesterday's AMA and LWAT percentages. We had no LWATs, and we did have one patient who was an AMA. It was a 65-year-old female who presented to the department with numbness to her face. I have already called her this morning, and she has a 10 o'clock appointment with her primary care physician.
Good.
We had no patients removed from presentation, and we had no transfers.
It is important to record every patient who presents to the ED for EMTALA recording purposes.
As you are aware, I have been really focusing on EMS command and trying to get more runs in here, and that has been effective, and it's reflected in our numbers. Yesterday we had a total patient run of 41% from EMS, and our month to date is at 23%, so that shows significant improvement.
If the ED were to have transferred patients, it would be at this point we would perform a detailed review. We would want to be sure we did not transfer patients we had the capability and capacity to treat. Tracking and reporting the EMS arrivals allows the team to determine if there are any changes in higher acuity patients. Forming partnerships with EMS strengthens the report. After the ED director completes his or her review, the ED doctor reviews the qual check.
Okay guys, this is what I have. Although I wasn't on duty yesterday, I reviewed all the charts and the reports. We came in at 19% on our qual check overrides, which is less than our 30% threshold.
Good.
So we did meet our measure. As Shannon had mentioned earlier, our physician consults for patients over 65 was 86%.
Very good.
As for our length of stay, our physicians and mid-level providers were under the benchmark of 2 hours. Physician exam time was 20 minutes, which was less than our 27-minute goal, and we had no unscheduled returns.
Wonderful. Great job. Thank you.
It is essential for the on-duty physician to review the peer charts to know which patients were discharged safely. The qual check reports identify patients at higher clinical risk of negative outcome. The nursing staff would phone these patients the next day to see how they're doing. Patients who are not feeling better would be directed to return to the ED for expedited admission to the hospital. These callbacks are documented in the medical record. The purpose of the flash meeting is not to justify the previous day's actions, but to critically determine if the right thing was done for the patient.
Let's now talk about our core measures. We have certainly had an increase in focus in improving the core measures, and yesterday's EKG from presentation time was only 4 minutes. Significant improvement. The total core measure report yesterday was at 100%, and that brings our month to date at 91%. So we're really excelling at that.
Great.
Our nurse acuity yesterday was increased 4.21, which is of course reflective of our overall admission rate. Testing guidelines were at 95%, so that also has increased this month.
Core measures documentation needs to be reviewed each day for opportunities. Our electronic charting system cannot recognize free text. the users need to select the correct core measure prompts in the system. When clinical staff understand missed opportunities, it can change behavior and improve future documentation compliance. It is important for the ancillary departments to not cancel tests in the hospital host system. This will negatively affect the nurses' triage testing performance. There is an approved set of triage tests that can be ordered specific to patient complaint. Not all complaints have tests associated with them.
Okay, let's talk about our MSE process from yesterday. We had 6 private pay patients come in. We were able to bedside register all 6 patients. We were able to collect from 2, so we did hit our percentages on the number that we needed to collect. We did, however, have an issue with one that probably should have been screened out. The physician that was on duty didn't understand about how to look at previous visits. And Dr. Stiles, if you'll get with her the next time she works and kind of go over the process, that way I think we could have prevented some expensive tests from being completed and the patient could have been screened out.
Absolutely.
Okay, thanks.
Hospitals typically place a resource management person with ED experience during peak hours. For example, Monday through Friday from 11 a.m. to 7 p.m. until there's enough volume to expand to 12-hour shifts 7 days per week. To improve patient flow, the team has a bed huddle meeting after the flash meeting each day. The team also makes adjustments to throughput and output, such as staffing and arranging transports the night before all discharges. Once this is concluded, the CEO follows with questions or observations. Each person in the flash meeting has the opportunity to ask questions to learn what processes could be streamlined to improve patient care and throughput.
Do we have any barriers from registration or any delays from lab or radiology?
Not that I'm aware.
Okay, good.
All right, y'all, good flash meeting. Let's head over to the bed huddle.
The person recording notes captures the main elements of the meeting and reports back on the status of any previous meeting request. For instance, if the EKG times are high because there is one machine for a large department, the team can discuss the possibility of borrowing an EKG machine until one can be purchased in 30 to 60 days.
Hello, I'm Daniel Nell, Chief Operating Officer here at Charlotte Regional. I've been in healthcare for 20 years and I've seen various systems management tools come and go. And I'm here to tell you, this is one system that really does work and works well. But it only works when everyone is engaged. Any team can rally around the process because there are clearly defined metrics and expectations, and it allows clinicians to focus on what's important: high-quality patient care. With metrics like AMAs and LWATs of 4.1% a year ago dropping to 0.8%, door-to triage times of 8 minutes a year ago decreased to 1 minute this year, and a length of stay of 3 hours and 48 minutes now down to 2 hours and 13 minutes, we have proven here at Charlotte Regional that this method works, and as you can see, the results are pretty impressive.
The ED flash meeting takes just moments each day. Time that is a significant investment in excellent emergency department flow and operations.